This podcast is for informational purposes only and does not provide medical advice. Always consult your physician or other qualified health provider with any medical questions and never delay care because of something you hear on this podcast. Welcome to Prostate Cancer Real Talk. Did you know that 1 out of 8 U.S. men will be affected by prostate cancer? And Black men are 50% more likely to be diagnosed and twice as likely to die from it. Meet Ellen Shea, a married couple impacted by prostate cancer who have faced it, fought it, and defeated it. Join in now where we answer questions, share personal stories, and fellowship in our safe, judgment-free space. Expert guests include urologists, surgeons, researchers, counselors, nutritionists, patients with their families, and more. If you or someone you know has been impacted by prostate cancer, you've found a welcoming place for information and support. In this episode, we welcome Dr. Kirtland Deville. Dr. Deville is an associate professor in the Department of Radiation Oncology and Molecular Radiation Sciences at the Johns Hopkins University School of Medicine. He serves as clinical director of Sibley Radiation Oncology and medical director of the Johns Hopkins Proton Therapy Center. His clinical expertise involves treating patients with prostate cancer and soft tissue sarcoma. Ellen Shea, take it away.
Thank you very much for that wonderful introduction, Dennis, and welcome to Dr. Deville and also Shea. Hello, doctor.
Hi there. Thanks for having me. It's a pleasure to be here.
Tell us a little bit about your story.
It was really when I was doing my rotations as a medical student that I realized I was drawn to the patients with cancer. I was drawn to oncology for whatever reason. I didn't really, in fact, I only understood it in hindsight and sort of looking back and really sitting down and thinking, because I had sort of this moment where I realized I didn't want to be an orthopedic surgeon. So what was I going to be? That surgery didn't speak to me in that way. And when I reflected back on my rotations, I realized in every specialty that I rotated through, I was always most interested in the cancer patients, whether it was medicine or surgery or OBGYN or any specialty, because really almost every specialty has an oncology branch because almost any cell in the body can become a cancer. And so that led me to oncology, and I was working with some oncologists during a clinical research year at Yale, and they referred a lot of patients to radiation oncology for radiation treatment. And radiation is quite an obscure specialty. A lot of people don't know about radiation. A lot of medical students and physicians don't get exposure to it in their training. So I was sort of lucky that I did get that exposure, and I thought it was really great. It was kind of an intervention-based specialty, kind of like that surgical mindset of have to create a plan and deliver that plan. And it's very anatomy based. You have to understand the anatomy, where's the cancer starting, where it might get spread to. So, and then you have technology, you have gadgets and tools and things that are constantly evolving and improving. And so all of that sort of melded into the perfect specialty for me to be able to work with cancer patients. So I did my residency in radiation oncology at the University of Pennsylvania in Philadelphia. And it was there where I really got drawn to prostate cancer. And the reason was I did my first rotations at the Philadelphia Veterans Administration Hospital. So the Philly VA is covered by the University of Penn. And so immediately I was, kind of struck there in West Philadelphia and seeing a lot of Black men. They would assign, there was a junior resident and a senior resident. A junior resident saw all the prostate cancer patients. So here I am, the only Black male in my program, seeing all these Black men with cancer, with prostate cancer specifically. And that sort of really struck me, sort of wondering what's going on to the statistics that you mentioned in the beginning, higher incidence, higher mortality. And back at that time, I don't think the conversation was not as evolved into the forefront as it is now and as it should be, understanding these statistics. It was almost as if you shouldn't really be talking about race and disparities, and you should focus on the biology and just sort of those aspects and not sort of bringing the full picture together to really understand what's going on. And I did my rotation then on the main campus early on, also in prostate cancer. So from the outset, it was kind of destined that I was going to focus on that as a specialty. And as radiation oncologists, as I mentioned, we treat all types of cancers. You rotate through all of the subspecialties, learn how to treat cancer across the body. But as I was finishing, decided I wanted to have that focus and was fortunate to stay on as a junior faculty member there at the University of Penn before I came over and joined Hopkins. So that's kind of my journey to radiation oncology and to prostate cancer specifically.
Have you considered a clinical trial as your next step? Pfizer is researching a potential treatment option for adult men with metastatic prostate cancer. You can learn more at www.mevpro-studies.com. That's MEVPRO-studies.com. So as we were chatting before the show here, we talked about radiation versus radiology. So could you tell us a little bit about the difference between radiation oncology and radiology?
Yeah, absolutely. And I take the opportunity. One, when I see patients in consultation and in the clinic, I say, hey, I want to make sure you are fully informed and educated and feel confident when you leave this room. They say that's Dr. Deville's patient. They know he's well informed. He knows about his cancer. He knows what matters, what doesn't, the indications, which I want them to feel really engaged and informed and not leave confused or like there's something they don't know. Always, of course, there's always questions that arise, but so specific to that question, patients often come in and say, you're my radiologist, or this is radiology oncology, those sorts of things. So I just take the opportunity to clarify. Technically, I'm a radiation oncologist. Radiation oncology is its own specialty that can treat prostate cancer and can manage prostate cancer. We can be your primary, oncologist, your primary doctor once you're diagnosed with treatment. Radiation oncology became a specialty out of radiology. So back in the day when X-rays and radiation, the ability of radiation was sort of being discovered, I'm talking about, almost over 100 years ago, there's sort of always been an imaging branch and a therapeutic branch. So diagnostic and therapeutics. And eventually somewhere, I think in the 60s or so, the field split and radiation, and then providers. So providers used to do both. Radiologists would do both imaging and therapy. And eventually it split. And if you decided whether you wanted to do sort of therapy training, which became known first as radiation therapy and then eventually radiation oncology. And so radiology obviously still exists as its own branch, and those are diagnostic radiology. So they're usually sort of diagnosing, taking imaging, scans, things like that. And radiation oncology is the branch that's handling the therapeutics, the treatment, the management. There's obvious overlap. We use imaging to design our treatments, to target tumors. So we get training in imaging. And overall, the American Board of Radiology is who certifies both diagnostic radiologists and radiation oncologists, and technically interventional radiologists, which is a third specialty within its own specialty within radiology.
Just a reminder, to ensure that you stay up to date on the latest episodes from Prostate Cancer Real Talk, don't forget to hit that subscribe and like button.
So to demonstrate this in kind of like a practical term, as you were talking, I was thinking about, somebody that goes and gets an MRI or an X-ray or something like that. The radiologist would read and interpret those results.
Exactly. The radiologist is reading that prostate MRI that we're going to talk about, and working with the urologist who may be doing a targeted biopsy or just referring the patient for their MRI. Once that pathology, the information is known on the cancer, and the patient is deciding on their treatment options, then they will come and see me. They will come and see a radiation oncologist who would actually design the treatment.
So I'm going to ask the first question here, and then I know Shay has some questions for you. As we're talking to men and our listeners about the decision, surgery versus radiation, okay? And I'll just use my own story as an example. When I was discovered to have prostate cancer, we had a choice on how we were going to treat it. Were we going to go with radiation, or were we going to go with surgery? One of the key decision makers for me was when my surgeon told me that once you elect radiation, then surgery becomes, he didn't say impossible, but more challenging and difficult down the road. So can you please talk to us about surgery versus radiation and some of the things that people should consider, a man and his family should consider when they're making the surgery versus radiation decision?
Yeah, absolutely. This is, frankly, the conversation I have, all day, every day, seeing patients now, some thousands of men with prostate cancers are working through this decision making. I want to address the last part first, and then I kind of take it back to the beginning, because I think it is really important. What you talked about, this idea of what happens if you need additional treatment after your first treatment. And there is some, I call it phraseology. I don't want to say the physician is saying something wrong or, sort of fully incorrect, but this statement that this idea that, well, you can have radiation after surgery, but you can't have surgery after radiation. Or technically you can have surgery and radiation, but it's very morbid. It's, there's a lot of complications and risks. That's often kind of said and left there. It sort of implies that there are not alternative options that are just as good at eliminating the residual cancer that might be left behind in the area where you had radiation treatment. So I hear that all the time, day in and day out from patients. And it's a little bit frustrating because it's somewhat misleading to sort of imply that there are not alternative options that are just as good.
So I just want to clarify something. Yeah. When you say you hear that all day long, the question that you're saying is that you hear that people are saying, once I get radiation, I can't have surgery. Is that the question that you're paraphrasing? Okay.
Yeah. And that's what's been told to them by their surgeon. Not to throw the surgeons under the bus, but that's what's been told to them. And it's not an incorrect statement to say that you would be unlikely to have surgery after radiation. I wish the additional sentence was said with it. You wouldn't have that because you have other options that are just as good at eliminating the residual cancer that are not as aggressive and morbid. There are things like cryotherapy, high frequency ultrasound ablation, focal radiation, repeat radiation. There are other treatments that we can have. This falls into a category of what we call salvage therapy. So again, that concept of what if your first treatment, doesn't work, I put that in air quotes. Mm-hmm. It's just that there's some residual persistence of the cancer locally. And what do you do? And so I say that because I don't want, and I tell the patient this directly, I don't want them to be driven by the thinking that I need to have surgery because I don't have a backup option. That's incorrect. You can have surgery because it's a good option for you, right? But don't sort of make a decision thinking that this is somehow the better option because you have a backup option that you don't have with the other pathway. So when we sort of back up and say our outcomes are just as good whether we have surgery or radiation, that includes the idea of needing salvage therapy, of any salvage therapy. Because if you had better outcomes with surgery followed by radiation, that would show up in the recurrence rates, the survival statistics, those sorts of things. When we can say that your outcomes are just as good whether you have surgery or radiation, that includes the idea of the need for any salvage therapy.
I feel really great about my surgery option. But what you're saying now is that had it not come back at 0.00, and if we had to go back and for a follow-up, we could have done that surgically. And what you're saying is that same option holds true for someone who may have gone in for a radiation treatment. Yeah. They still have options.
Exactly. So just to sort of just to kind of get clear up what you said. So if the PSA is rising after surgery, then one of the options may be to do radiation to that what we call the prostate bed, the space where the prostate was removed. And so that's a standard option. And you do, in the other sort of reverse scenario, the patient had radiation first, they're being followed, PSA goes down, but then starts to rise. If there's some cancer that's, picked up that's still active within the prostate, there are local therapies that can be delivered to the prostate and have just as good outcomes. Yes.
Okay. If a person has radiation instead of surgery.
Yes.
Talk to me about that, because we don't really know anything because we went the surgery route. So talk to me about the process of going through radiation to treat prostate cancer.
I'm not an expert in it, but there are people who are dedicated to this question. There's a whole field of treatment decision-making, treatment regret, those sorts of things in prostate cancer management because, and that's sort of more understanding the psychosocial and how, in terms of outcome, physical outcomes, but also, mental and quality of life and those sorts of pieces, because you have multiple options. Sometimes I tell the patient, you have a menu of options to choose from. We are not going to end this conversation by saying this treatment is better than that treatment. We're going to end with that menu. And our job here is to think about what suits you best. What are you a good candidate for? But sometimes you can be a good candidate for everything. Understanding what you're a good candidate for, and then working through in the shared, what we call the shared decision-making process, me understanding your values, what you seem to be prioritizing, and which of those options might best suit that. Because at the end of the day, many patients are going to end by saying, well, Dr. Deville, what would you do? Or when I was younger, they would say, what would you do for your father? Now they just ask me, what would I do?
Oh, you still look young, so.
So back in the day when they would say, what would you do for your father? I would say what my father would do is different than what my uncle would do in the exact same scenario. So it's not about me imposing my bias. It's really thinking about the individual. What am I hearing from you and what may suit you? It may be radiation. It may not be radiation. It may be surgery. And I say, go have your surgery. You're great. Looks like you're a great candidate for that. So I think, it's unfortunate when I do hear, that's why I'm so happy to be here in this conversation today, because I often do hear that, patients, have to stumble on their own on radiation oncology or about, hearing about brachytherapy, the internal radiation, the seed implant, or things like proton therapy, sort of unique things within radiation treatment. And they're not necessarily being referred. Generally at most, hopefully most academic medical centers or sort of larger practices in work in oncology, we want to work in multidisciplinary teams and in a multidisciplinary fashions. Most studies show you have better outcomes when you work that way in oncology. And so, we are fortunate to partner with our urologists, and they refer us to patients just to hear about radiation, just to make sure they've heard about it up front. And I may often do that. I may see a patient as a second opinion coming from another institution. They want to hear about radiation or protons or something very specific. But if it sounds like, I ask them, have you been well counseled on surgery? Do you feel like you've heard about that? Do understand the outcomes? And if they say no, I'll refer them right away to one of our urologists to make sure. I want them to, like I said in the beginning, I want them to be fully well informed about their cancer, their treatment options, and all those sorts of things, whether they're ultimately getting treatment with me or not. But let me walk it back to the beginning of how do we understand or think about radiation treatment? So usually by the time I see the patient, they've been, just as you told your story, they, been screened or diagnosed, we understand the Gleason score, their cancer. So we're sort of putting it all together to understand what their management options are. We use nationally and internationally, if the cancer has not spread, so we're talking about a localized prostate cancer, because if it's spread, they're off to see a medical oncologist, get hormones and what we call systemic therapy. And they're not really focused on radiation or surgery, like a local treatment option. But if the cancer is localized, meaning we don't see any obvious signs of spread or sort of contained within the pelvic area, they're going to be a candidate for curative treatment. The curative treatment pathways, I tell the patient, is surgery or radiation. You can take the surgery road or you can take the radiation road. So for the surgery road, I'm going to let the surgeon focus on that. I'm going to make sure they're well counseled on what are the logistics, the risks, the operative risks, the side effects, what's the techniques that's being used, are the nerves being spared, all those sorts of things, really making sure they understand that. And in fact, as the surgeon told them, they're a good candidate for surgery. With radiation, I'm going to focus on that pathway and talk about the various forms of radiation. But one of the key things I wanted to say, so nationally or internationally, we use what's called the risk group stratification. Right. So we need to classify that person's prostate cancer to know what are the appropriate treatments for it. And so that's defined as low, intermediate, or high risk. And it takes into account your PSA, your Gleason score, and your tumor stage. Right. And so a person with Gleason 6, usually I tell patients the Gleason score, that marker from the biopsy tissue, the score that was assigned to those cells, marker of sort of aggressiveness and risk, its potential to spread. That Gleason score is historically the #1 predictor of long-term outcomes. This is why we put so much kind of focus into it. So that Gleason score that the pathologist assigns when he looks at those slides under the microscope, that worst Gleason score is what usually drives that risk group stratification. So if it's a Gleason 6, 3 + 3 = 6 pattern. 3 are the cells that are the least aggressive appearing and don't really tend to spread. So that's Gleason 6 low risk prostate cancer. Nowadays, the number one management for Gleason 6 low risk prostate cancer is no treatment, is what we call active surveillance, monitoring, close monitoring. I used to say historically it was watchful waiting. Now we changed that term because watchful waiting was, go away and come back when you have a problem. We know we don't want that. We want to keep a close eye on the patient. So active surveillance is we're going to keep a close eye on your prostate cancer, and we're only going to treat it when it's showing signs of becoming more aggressive so that we don't have a problem down the road like spread or death from prostate cancer. That's usually something like a PSA every 6 to 12 months, a biopsy, an MRI every year, so that, again, you can kind of jump in at the signs of earliest progression of the cancer. So that's Gleason 6 low risk prostate cancer. There are some scenarios where they may move on to treatment earlier, or we might sort of think about still treating, but just at a sort of basic level, that's what's happening. That's the primary recommendation for low-risk prostate cancer these days. And the urologists usually follow the patient in that setting. So we don't even really see those patients anymore. With Gleason 7, that's defined as intermediate risk prostate cancer. So now the cells are behaving a little bit more aggressively. They have the potential to spread, invade locally or spread. And so that's where we're recommending treatment. Unless the patient has a life expectancy less than 5 years, then you may just kind of do a monitoring strategy. But if more than that, they're likely going to live long enough that the cancer could cause a problem in their lifespan if you don't do something about it. And so that's where we're doing treatment. And then the next category just beyond that is high-risk prostate cancer, which is if your Gleason score is 8 to 10, that's as high as the scale goes, that those are the patients that really have a higher risk of cancer progression, and they need more comprehensive treatments. The one thing I will add is, so we use the risk group also to say whether the patient is a good candidate for surgery or radiation. In the high-risk group, especially if it's what we call very high risk, there's already signs, say on the MRI or on the PET scan, the imaging scan, that the cancer has spread to, through the shell of the kind of capsule of the prostate into the glands that sit on top called the seminal vesicles, or if it's in an adjacent lymph node, the lymph nodes that are sort of beside the cancer, the prostate that, the cancer cells like to try and escape. They're using they're trying to figure out ways to escape the prostate. If we see any of those signs, very often those patients are less likely to have surgery. They're actually more likely to have radiation because we're already seeing signs of the cancer moving beyond the prostate. So all of those things are what we're sort of analyzing and thinking about and explaining to the patient as what influences whether one treatment might be better for them or not. But in principle, like say in your situation, very commonly in that intermediate risk box, they're going to have the options of surgery or radiation. So then I tell the patient age can become an important factor, because age is often kind of a surrogate for other medical issues, how the patient is going to tolerate and recover from surgery. So sometimes you hear things like everyone over 70 is kind of steered towards radiation, everyone under 60 is steered towards surgery, and 60 to 70 goes either way, depending on their overall health status, their personal preference, their other medical issues. And so, right, if you're in that 60 to 70 box, you're right in the middle where you could go either way, depending on these factors. Some of the things that influence the age piece are kind of what I was mentioning, that ability to tolerate surgery. Over age 70, if the person has multiple medical problems, there may be risks of anesthesia, things like wound healing and recovery, in diabetics and other patients may present issues. And actually the recovery, the rates of leakage and incontinence. So, right, the person after surgery is wearing a pad, they may be dribbling or just leaking, not have control. And generally young men and very young men will recover well, not even have any leakage or minimal, and do their Kegel, their sort of strengthening pelvic floor exercises, and not need a pad. But those rates of not recovering go up with age, particularly over age 75. So that's why very older men are generally not going to be advised to have surgery. On the flip side, very young men are generally going to have surgery because they're going to tolerate, they're going to recover well, especially if they don't have very advanced disease. The cancer is entirely limited and contained to the prostate, and they can hopefully be one and done. I always tell patients, because sometimes they say, oh, it can come back after surgery. Absolutely, it can. No treatment is 100%. Those cells could have escaped the prostate. But, hopefully they'll be able to, if they're very young, cancer's unaggressive, they can just have the surgery. And one of the rare risks with radiation that does not it's maybe not at the forefront of the conversation sometimes, but can be important for very young men, is the risk of creating a new cancer from radiation treatment. And so anytime, one of the ways radiation works is creating DNA damage. The cells are made of DNA. Cancer cells are constantly dividing. They're more likely to have their DNA exposed. We hit it with radiation every day, cause DNA damage, and those cells die. That's how radiation just fundamentally works. But if you have normal cells that are dividing, and get DNA damage, they may get mutated and not die off. And that could years down the road, become a cancer, maybe like 5 to 10 years at earliest. So we usually quote like 0.5 to 1%. The risk is very low. But, I tell patients, you treat hundreds or thousands of patients, statistically, somebody is going to be that person who gets that secondary cancer 5 to 10 years down the road. So for very young men who have decades and decades and decades of longevity, if it's a 50-year-old, you're projecting 35 years of longevity in the United States, that might be a bigger concern, that risk, than say a 75-year-old where you're not projecting the same lifespan. And so those are things that can influence that decision-making, and why very young men often have surgery. And we as radiation oncologists are not sort of arguing with that at all. We know that in balancing those factors, that's likely very appropriate.
All right, Dr. Deville, thank you. And thank you so much for being on the podcast.
Thank you, guys.
The study medicine in the MEVPRO clinical trials is designed to block the abnormal EZH2 activity in cells. With the study medicine's help, the abnormal EZH2 no longer promotes cell growth, and the flow of traffic returns to its normal state, and tumor growth is delayed or prevented. The goal of the MEVPRO clinical trials is to determine whether this study medicine, taken as tablets by mouth, is safe and effective. During these clinical trials, you will have regular visits to the study site, and your health and cancer will be closely monitored by medical professionals. You may experience side effects from the study medicine, such as diarrhea and fatigue. More information will be provided during the informed consent process.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, ellandshay@prostatecancerrealtalk.com. That's L-E-L and Shay, S-H-A-Y, @prostatecancerrealtalk.com.